When you're thinking about how someone identifies themselves, right, I think it's important to remember that gender is up here, right? And so how we identify ourselves comes from up here. I may look like a man, but identify as a woman. And so one of the most important things I've learned in this field is not to make assumptions and just to be willing to be ignorant and ask questions, because many of our patients are willing to educate us. It's when we make assumptions that we get in hot water with our patients. And I can give an example. Early in my career, I had been working with a woman who I knew identified as lesbian. Because we had had a conversation about it. And she was getting ready to go home. She was getting ready to be discharged. And I went into her room, and there was another young woman sitting next to her. And I knew she had family in town. She had a couple sisters. And I made an assumption. And that assumption was that the woman sitting next to her was her sister. And so when I introduced myself and I said, "Oh, are you her sister?" they both kind of looked at each other a little uncomfortably, because you never know who's safe. And although this patient and I had built good rapport, and I knew that she identified as lesbian and we had had a conversation about her partner, my assumption created a discomfort for them and a little bit of a break in trust in our relationship, because I didn't say, "Hi, I'm Sage, I'm the social worker working with," and you are. Right? It would have left so much more room for us to have a different conversation than the little bit of distrust that I placed in there. So when we think about asking people about, even just in our intake forms, if we only have male, female, there are a lot of people who don't identify as male, female. And so we have an opportunity as clinicians to change some of those forms to say male, female, transgender, intersex, or other. When we think about even our identity around relationship status, many places still have marital status listed on that. And so changing that to relationship status, single, partnered, right? Because you can be in a same-sex partnership, you can be in a heterosexual partnership, but not be married. And leaving open areas, partnered, divorced, widowed, single, married but divorced, however we can do it to make it more inclusive. The more inclusive our first impression, or that piece of paper that we put in front of patients or the screen we put in front of them, the more inclusive that intake is, the safer we are to those patients who might identify as LGBTQ or intersexed or transgendered. For the LGBTQIA community, I think we already know that there's a lack of distrust or a lack of trust. There is distrust in the medical community based on years, especially in the elderly LGBTQ community, where it wasn't safe to come out to a physician or a nurse or a social worker because of the ostracization and or the lack of education that many of our clinicians had, and the fear of judgment or being outed around their family. So being able to ask the question, do you have anyone significant in your life? Do you have a partner or partners? Because again, when we limit it to one, there are people who have multiple partners, and that doesn't mean they're polygamous. They may just have multiple people they're dating. And so even the general questions we ask people, I often, if I don't know, I'll say, do you have a boyfriend or girlfriend, or boyfriends or girlfriends? Do you have a partner or partners? Trying to use very gender neutral and relationship neutral language allows for that patient to feel safe immediately. And although they may, try to scoot around it, especially our older LGBT patients, over time, the more that you use general language, the safer you become. The information you provide them is not any different. If you are working with a man who identifies as a heterosexual versus a man who identifies as gay and talking about erectile function, the information you provide is going to be exactly the same, and same with someone who identifies as a lesbian. The difference, though, if we're thinking about gay men who have been diagnosed with prostate cancer, oftentimes in gay partnerships, there is an assigned role for each of them, just like there are in many other relationships. So one partner may be the top and one might be the bottom. If the male diagnosed with prostate cancer was the top, and he no longer gets an erection in the way that he used to, it has tremendous, tremendous impact on their sexual relationship. And so oftentimes when I'm working with a couple that identifies as gay, it's just that grief first, the identification of loss and grief, because they can't have sex the way they used to. You can't penetrate an anus with a flaccid penis. You can a vagina. And so there's a different conversation that I would have with a heterosexual couple with a man with prostate cancer versus a gay couple with a man with prostate cancer. And both of those start with loss and grief around the changes that have happened, and that there are a lot of things you can do to stay connected physically, intimately, and sexually that can be just as satisfying. They're just going to be different.